by our dedicated nurse clinicians improve adherence to a 1-to-1-to-1 transfusion ratio compared to the traditional resuscitation strategy by anesthesia. So as an introduction to our center, since 2009, we've had a program for critical care nurse clinicians, 1997, and they primarily have driven the massive transfusion protocol when it's initiated in the trauma bay. They also deal with assisting with the workup and care of trauma patients. And so it was a logical conclusion, if they're driving this resuscitation strategy in the emergency department, if we brought them to the OR, would this help us to adhere to our massive transfusion protocol? So this was started in June of 2015. As far as our methods, we're a level 1 trauma center. This was a single center retrospective review of a prospectively maintained database between these years. Inclusion criteria included traumatically injured patients greater than 18 years of age who required a massive transfusion protocol initiation and operative intervention for definitive hemorrhage control during the first 24 hours. So our pre-intervention group was from the initiation of our massive transfusion protocol in January of 2007 to May of 2015. And then we started bringing our nurse clinicians into the operating room in June of 2015 until January of 2017. The following data were collected, including individual blood components, age, sex, injury severity score, and mechanism, as well as 24-hour mortality. And then demographic data, injury mechanism, ISS, blood product ratios, and volume of crystalloid were compared. All continuous variables were compared with a student's t-test or a Fisher's exact test, and then the non-continuous variables were compared with a chi-square test. As far as our results are concerned, in the pre-intervention group, which was the group prior to introducing our nurse clinicians in the operating room, we identified 53 patients, and in the post-intervention group, we had 44. As far as our results are concerned, this is a table talking about the age and injury severity score comparison between the two groups. You can see here the p-value demonstrates no significant difference between these two groups. This is a slide demonstrating that there's no gender difference between the two groups. And then between blunt and penetrating, it was statistically significant that we had more penetrating trauma in the post-intervention group. As far as intraoperative ratios of blood product administration, you can see here that this is the pre-intervention group, and this is the post-intervention group. And there was a trend toward reduction in the ratios of packed red blood cells to plasma with a p-value of 0.11, and then a statistically significant difference here between the ratio of packed red blood cells to platelets. As far as to try to determine, since we saw a breaking point above 2-to-1, we wanted to see how closely we adhered to at least having patients less than the ratio of 2-to-1 blood to plasma. And you can see here that we did have a reduction, although it failed to reach significance. As far as intraoperative crystalloid is concerned, there was a large difference observed here in the pre-intervention group here, average of nearly 5 liters, and the post-intervention group of 1.6 liters. And then for 24-hour mortality, 40% in the pre-intervention, 25% in the post. So in discussion, again, we found that the populations were comparable aside from the more penetrating trauma being present in the post-intervention group. We didn't find a significant difference in packed red blood cell to plasma ratio. However, this did trend towards significance, and there was greatly decreased variability looking at the standard deviation. There was a significant difference between the ratio of packed red blood cells and platelets. Trend toward decreased incidence of these ratios greater than 2-to-1, as we discussed earlier, and then significantly less intraoperative crystalloid was administered in the post-intervention group, and a trend toward decreased 24-hour mortality as well. And here are my references, and I'm happy to take questions.
Anybody get the time? How'd we do on the time? How'd you do on the time, Andrew?
2 minutes over.
Okay. Questions, comments, observations? Dr. Maxwell?
I think you need to debride some of the background information in the beginning about previous studies. These quick shot things are supposed to be very brief introduction and then straight to your data.
Okay. Yeah, I need to prune that a little.
What was the real point? What do the red shirts do? That's different in the OR. I mean, when they go to the OR with you, what do they do?
I think they are just able to focus exclusively on being able to adhere to our protocol. So they administer it before they kind of have records of how many units
they're
they
monitoring your transfusion input. Is that what they do in the OR?
They get it. They have established a communication with the blood bank. They get on the phone. They're talking to the blood bank the whole time, telling them, you know, where they are and what they're going to need and when can they get their next cooler of blood. Before, when the CRNAs predominantly managed this, they just stood there and they were helpless shrews. If somebody brought them some blood, they would hang it.
Okay.
And so we have a much more interactive team that understands how the blood bank works, cares about trying to maintain the ratios, and they just stand there and that's all they do is give the blood. And sometimes they bring two of them in the operating room. And so,
because to me, like you say, I would try to limit some of the other discussion and try to emphasize what is different about this, because I don't think very many people are doing this, and that's the real focus, is it not? I mean,
yeah, he needs another couple of bullet points in the conclusion about the actual nurse side of this and not just the data.
Yeah, because what your objective is to use them to keep you closer to the one-to-one-to-one, is that right?
Correct.
And I mean, I didn't get that clearly myself. I mean, I guess I should have maybe.
Yeah, we've been polishing this thing up the last minute. We got to add a couple of bullets.
But I mean, those are just the two things I would do, is try to make sure that what do the nurses, what do they do? Really slow down and make that clear. That's what they do in the ER, and they follow you to the OR and continue through the case, right?
Yes, sir. I think I can cut out some of the, I mean, everybody knows what a master transfusion program is.
I think highlighting the biggest point that came out of this from since I looked at it, was the crystalloid difference, and really highlighting that and how instituting this has really limited the crystalloid, since that's a statistically significant, and it's pretty significant, a 4-liter difference almost. You know, that's a pretty profound difference in just intraoperative IV fluids. And then, like they were saying, you know, highlighting how they manage the resuscitation, and then once they transition to the OR, they manage just the level 1 and the blood product administration.
So that at the end, it kept us closer to the one-to-one-to-one and reduced the crystaloid.
Right. Really highlighting that, because that's such a, a critical thought process.
And since you had a trend toward improved mortality, I mean, this.
If we ever get around to the point where we're ready to write a manuscript for this, we need to look at some additional outcome variables like length of stay and ventilator days, pneumonia and things like that.
And I guess I'm sure you're going to be able to try to explain why you had a difference in blunt and penetrating trauma. I mean, that's not the point of but I mean, somebody in the audience might ask that. I mean.
Well, yeah, the other thing we need to do is try and get a logistic regression analysis on those data points that he obtained, trying to pull some of them together still.
Okay.
There are probably not many places that do something like this that have a dedicated essentially a resuscitation nurse.
Yeah, my question was, how did you get the anesthesia to turn down the stinking crystalloids? I mean, you'd have to sit there and watch them, because they're going to run the things wide open. I don't know how you did that. And I don't suppose you check platelet counts and coag studies during these resuscitation things?
We usually, we'll get labs at the very beginning, but usually until we get definitive control of the hemorrhage, we don't usually recheck, because it's such a time-sensitive thing. We'll be behind 30 minutes, by the time everything comes back.
Other questions, comments? Yeah. Dr. Swafford?
Where do these nurses, what are they doing when they're not ensuring compliance with the master transfusion protocol? Because 44 cases in 2 years or something. Where do they come from? Where are they hanging out when they're not
So there are, yeah. So they're involved in the initial workup of all trauma patients and care of the trauma patients, and then they also will take care of medically sick patients as well. So there's usually one who's working with the trauma patients and one that's working with the.
This is part of the on-call team that follows on from the trauma bay straight to the OR.
Yes, sir.
And we've had the red. I don't know. We've had the red shirts as a part of our trauma team for maybe 20, 25 years. I don't know, something like that. Wouldn't it be? 97. Wouldn't it? Huh?
97.
97. Okay. So right at 20 years then. 21. Okay. Okay.
I had one quick.
Yeah.
Just on the actual slide itself, the kind of the big money data that you have, put in a big box or something, some way to really highlight, draw the eye to the big numbers that we're trying to put out. I think maybe of slight benefit.
Like on the discussion slide.
Yeah.
Yeah.
Or in your data and all that kind of stuff. Just things that draw people's eye to the really good data.
Would point out for everybody here in little old Chattanooga, Dr. Holcomb, who is really the father and thought leader in this transfer to the one-to-one-to-one, has been a guest Grandrounds speaker here twice. He's a really fine man, done a great job with that. All right.
All right, like Dr. May, I have 7 minutes, so we're going to time it. Good morning. Thank you to the Southeastern for the opportunity to present this morning. My name is Jacob Lloyd. I'm a third-year surgical resident at the University of Tennessee College of Medicine, Chattanooga. And today I'm going to talk about negative sestamibi scans and how they predict lower likelihood of referral in patients with primary hyperparathyroidism. I have no disclosures. Brief outline, I'm going to go over some background and then talk about our hypothesis and objective of this study, review the study design, go over our results and some conclusions. So briefly in background, parathyroidectomy is the definitive treatment for primary hyperparathyroidism after a diagnosis of primary hyperparathyroidism, which is a biochemical diagnosis. It's recommended that referral to an experienced parathyroid surgeon be made. However, the literature does note poor compliance patterns. 2011, Shapey et al. Identified that over 63% of their patients with primary hyperparathyroid disease remain untreated and were not referred to a specialist, and they looked at a little over 100 patients. 2012, Yi looked at over 3,000 patients, and they actually looked at the International Workshop Consensus Guidelines, which were published in October of 2014, and only 50% underwent surgery even after meeting guidelines. More recently, in 2017, Kuo looked at the extent to which the clinical consensus guidelines were followed at their hospital system, and overall they found a compliance rate of about 30.8%. We have also noticed similarly poor compliance patterns at our institution. However, this has never been evaluated and validated through surgical research. So our hypothesis was that negative sestamibi scans would equal less endocrine surgery referrals and thus less surgery. So the objective of our study was to determine the impact that these negative sestamibi scans were having on both referral patterns and rates of surgical intervention. Our study design, this was a single institution review. This was a retrospective chart review. We looked at all patients with a diagnosis of primary hyperparathyroid disease who underwent a sestamibi scan from January of 2011 through May of 2017. We included 347 patients in our analysis, and this is a chart of our data. We looked at demographic data. We looked at the ordering specialty of the physicians who ordered the sestamibi scan, the result of the sestamibi scan, whether it was positive or negative, whether the patients were seen and evaluated by endocrine surgery, and whether or not they got operation. As you can see, the majority of our patients were over 50 years old. They were female, and the majority of sestamibi scans were ordered by endocrinologists at 36%. So our results, I'm going to walk you through a flowchart diagram of our entire cohort and their ultimate surgical result. So like I said, we had 347 patients total. Of those, 186 received a diagnosis of a positive sestamibi scan by the radiologist, or a little over 50%. The remaining 46% were negative. Of those positive sestamibi scans, approximately 72% were seen by an endocrine surgeon. Of the negative sestamibi scans, approximately 57% were not seen by an endocrine surgeon. Of those with a positive scan that were seen by endocrine surgery, 82% ultimately underwent parathyroidectomy. Of those that were not seen by endocrine surgery that did have a positive sestamibi result, approximately 78% did not undergo surgery. I compare this to those with a negative sestamibi scan who were seen by endocrine surgery. 76% of them did undergo surgery. Compared to those that had a negative scan and not seen by endocrine surgery, only 2% underwent parathyroidectomy. So we looked specifically at those with negative sestamibi scans, and we did statistical analysis on these patients. And so of those that were seen by endocrine surgery and underwent parathyroidectomy was 77% of the patients. Compare that to those who were not seen by endocrine surgery that ultimately went parathyroidectomy. Now, these are patients with primary hyperparathyroid disease who need a parathyroidectomy, only 2%, meaning that 98% of them did not get parathyroidectomy. So there was a statistically significant association between those with a negative sestamibi scan who were seen by an endocrine surgeon and underwent surgery, and there was a strong association such that those with a negative MIBI who were evaluated by an endocrine surgeon were significantly more likely to have a surgery. We looked further and we backed up and said, well, what about regardless of sestamibi scan? So we looked at all patients that were seen by endocrine surgery and were not seen and whether or not they underwent operation. So those that were seen by endocrine surgery and did get surgery ended up being about 80%. Those that were not seen by endocrine surgery and did not get an operation was 90%. So only 9% of patients who were not evaluated by an endocrine surgeon ended up with an operation, regardless of their result of sestamibi scan. This was a statistically significant association, such that regardless of the patient's sestamibi result, if you were seen by an endocrine surgeon, you were more likely to undergo parathyroidectomy. So briefly in discussion, negative sestamibi scans were significantly, did influence referral to endocrine surgeons and thus the likelihood of undergoing a parathyroidectomy. Those with negative scans were less likely to be referred to an endocrine surgeon and thus less likely to undergo parathyroidectomy. So being seen by an endocrine surgeon resulted in a significantly higher chance of undergoing a parathyroidectomy regardless of the patient's sestamibi result. A few limitations and assumptions of our study. This was a retrospective review, and as such, there could be variables that were not examined in this study that could have contributed to both the referral decision and the decision for surgery. We did only review data from the primary teaching institution in Chattanooga. We do have 3 hospital systems, 2 of which are private. And we looked at why the 24 patients that did have a positive sestamibi scan and were evaluated by endocrine surgeons did not get parathyroidectomy, and some of the things we came up with were either advanced age, patients' medical comorbidities, or they were just unfit surgical candidates. So in summary, negative sestamibi scans should not preclude evaluation by endocrine surgeons. Significantly more patients will undergo parathyroidectomy when they're evaluated by a qualified surgeon. We do feel that non-endocrine surgeons are likely utilizing sestamibi scans improperly as diagnostic tools rather than as localization studies. And in order to maximize cure rates, we believe that every patient with biochemical evidence of primary hyperparathyroid disease needs evaluation by an endocrine surgeon. And with that, those are my references, and I'd be happy to take questions.
How'd you do on your time?
20 seconds under, so pretty good. I have a little bit more time.
So the way the
It slowed down just a little bit. That's good. Yeah, that's better than last night.
Yeah. So the diagnosis was made with biochemical
yes, sir.
Analysis?
Yep.
Okay. All right. And so who else, in your discussion of who ordered them, endocrinologist, I guess you can kind of understand, but who else, who was second in the?
We were.
Surgeons were?
Surgeons.
Okay, so. Okay.
Yes, sir.
Okay. Yeah, Dr. Giles.
So that was good, Jake. So Jake finished the paper up. We submitted that Monday, and then he got this together. So it's the first time we've kind of been over this together. I looked at it last night, so we got some cleaning up to do. But just like in the paper, I think we're going to have to focus on, you go too many times you go between they did not get surgery, and then this is the people that did. You go back and forth between the positive and the negative too much. We've got to figure out a way to present this so that you're thinking about all the same variables. You switch back and forth between when it was a positive, maybe these people got surgery. When this is a negative, maybe these people didn't get surgery. So we got to figure out a way to make that streamlined, because even for me, it gets hard to follow when you're going down through that algorithm and you're switching between positive and then negative and positive and negative. So we just got to figure out a way to do that. There's a couple of other things we got to take out improperly. on the end. We can't say that. I mean, that's not we can't say that they improperly use these. These are assumptions we're making based on data. So we can't say that these other surgeons were using these tests improperly because, like I said, we don't know this. So sure. That's a statement we shouldn't make for sure. And then at the beginning, I think probably you had plenty of time, but you're going to obviously want to slow down.
Yeah.
And so maybe on some of the background information, we can just say several studies show, and then maybe highlight one of them and have them up there so people can read them rather than going through all the statistics on each one of the things. But that's something, as we start to fine tune this, we can go through.
Instead of saying it properly, can you, I don't know if it would be helpful, but talk about the false negative rate of MIBI scans and just say that when you have this level of false negatives, then you're going to inevitably have a certain number of people that fall through the cracks. I think that'd be a pretty easy way to kind of go around
you really
that.
You need to emphasize the fact that you really need to educate primary care people is that a MIBI scan is not a diagnostic test, it's a localization test.
Right.
Is that not right?
Yes, sir. It's absolutely
I mean,
right.
I think I'd say that pretty strongly. You know, one thing I do like for the presentation, though, I really like the way you've done that slide in terms of the things that you put the red box around, because that's a very busy slide. But on the other hand, I mean, that's fine. You've collected a lot of data, but you're going to point out. I like the way you did that myself.
Thank you.
One thing that might help to fill up that 20 seconds is include some data about your outcomes and your findings at the time of surgery. I mean, it's kind of no surprise to anybody that if you send a patient to a surgeon, he gets surgery.
Yeah.
And so you might want to include some data that says, what were the findings at the time of surgery? Maybe include some data that says what was the difference between the people that had a negative SESTA-MIBI scan, what surgery was done, was it a four-gland exploration, was it a single adenoma that was identified, and how many had 3.5 gland resection, and maybe a line in there about the results. Who was cured from their how many people were cured from their hyperparathyroidism? That would kind of lend a lot of credibility, I think, to your study results.
That follow-up to Dr. Swafford's point, I mean, sending a patient that might have hyperparathyroidism to a surgeon and seeing if they need surgery is a lot like asking the barber if you need a haircut, in that respect, I think. Yeah.
Quick question. I don't know if I was sleeping, but where did you get the patients from?
Where did I get the patients from?
Yeah, 347, if some of them never came to see you.
Right, so I looked up every SESTA-MIBI scan that was ordered through Erlanger Health System. So that's where I started from. I literally went into PACS and typed in parathyroid, and it gave me 300 and some odd patients, and then I excluded the ones that.
And you know that the ones that didn't get surgery by our surgeons didn't get surgery by anybody else?
Not necessarily. That's one of the assumptions.
So one of the assumptions would be that knowing the referral patterns here, that most of those are going to end up with one of us. But one of the limitations, obviously, is that it's possible that somebody got a MIBI here, even though most of them were done by either us or endocrinology, who tend to refer to us, and then but if they had their surgery here, we would know it. So that's the other big assumption, is that they probably had their surgery in this system. If they didn't, if they went to Memorial or Park Ridge, we can't capture that data. That's going to be a small percentage, and obviously is going to lead to some error. But with the numbers the way they are, 2% versus 90%, even with that error, we feel like that our results should continue on and be okay. The other part of this is the reason why we can't say a lot of this is 100% because we couldn't get IRB approval to look at the other hospitals. So if we could have gotten IRB approval to look at the other hospitals, we could have known for sure exactly how this was lining up, but unfortunately we couldn't do that.
Dr. Huggins, did you have a question? No, that was it. Okay.
The patients that never saw an endocrine surgeon that got surgery, I was just wondering, is that ENT? How did you know? Okay.
I found them. If they were here, I found them.
Okay.
Everybody at Erlanger, regardless of who operated on them, I looked at Net Access through Epic, and I found all those. But like Dr. Giles said, if they were at Memorial or Park Ridge, I don't think.
Any other questions or comments? Okay. Good job, Jacob. Okay, Dr. Capote.
Good morning. My name is Walter Capote. I'm a first-year resident at the University of Tennessee at Chattanooga. Today I'd like to present to you an interesting case that I saw in my pediatric surgery rotation. We received a transfer from an outside hospital of a 34-week gestation neonate. He was transferred for reported omphalocele rupture. On presentation, he was noted to have this fleshy T-shaped mass protruding from the umbilicus, and this is shown on figure 1. And it was protruding from what appeared to be a ruptured omphalocele sac. He was taken to the operating room for exploration, and the omphalocele sac was dissected and the midline incision extended cranially. It was then apparent that he had intussuscepted and prolapsed segments of proximal and distal ileum through a fistula tract connecting the ileum to the anterior abdominal wall, and this was consistent with an omphalomesenteric duct fistula. He was also noted to have malrotation, and this was shown in figure 3. The involved segment of ileum was resected, and the small bowel anastomosis performed in a hands-on fashion. I know he also had a LADS procedure performed with appendectomy at the time of surgery. The fascia was closed and the umbilical defect was repaired. He was returned to the NICU in stable condition. His postoperative course was actually uncomplicated. It was prolonged only by slow return of bowel function and tolerating PO feeds. This case highlights an interesting presentation of omphalomesenteric duct defect. This connection between the yolk sac and the GI tract persists usually up until weeks 9 through 10, at which point it involutes. However, in 2 to 3% of the population, this duct remains in some fashion. There's a multitude of ways where this can present, and this is shown in figure 4. You can have an umbilical sinus, you can have an omphalomesenteric duct cyst. There could be a fibrous band connecting the ileum to the anterior abdominal wall. You can have the more common Meckel's diverticulum, or you can have, as in this case, a complete patency of the duct and a fistula tract, and this can present with or without prolapse. Symptomatic presentations of omphalomesenteric duct defects being bleeding, infection, or small bowel obstruction need urgent exploration and repair. Review of the current English literature only yielded 2 other cases where omphalomesenteric duct fistula with prolapse was involved with an omphalocele. A rare case like this sheds light on the more common presentations, and our hope is that this will lead to earlier diagnosis, earlier surgical intervention, and overall improved morbidity and long-term outcomes for these small patients. Thank you very much for your time and allowing me to present today, and we'll be happy to take any questions.
Okay. Questions, comments, observations? Are you going? Now, this is going to be on the walk-around rounds
yes,
with
sir.
your poster, Walter.
The 3-minute presentation,
Okay.
2 minutes.
All right. Now, you need to have a pointer, either
Okay.
flexible pointer, telescope, or to me, and point out what you're talking about.
Yes, sir.
I mean, I thought it was pretty clear, I guess, if you're sitting back here and you kind of follow through it, but I think it might augment your presentation some to point at what you're talking about, because now the picture on the figure 1 is that's what the baby looked like on the OR table or in the emergency room.
Right, sir, that's when he
point
presented.
out what it is you're talking about, see, because I can't really tell from back here. I don't know, maybe others can.
Yes, sir.
That's a good point, Dr. Burns. So just have a laser pointer with you,
Okay.
and then you can sort of circle what you're pointing
You
at.
don't need to do, the verbiage you used was fine as far as I'm concerned. Dr. Moore?
You should also, if you haven't been there before, you should know that sometimes they set the posters up in not a very good way, and there's sometimes a crowd next to you, behind you, over on the other side. So make sure you take command of the people that are standing in that semicircle in front of you, so that you're loud enough for them, clear enough for them, because otherwise they can't.
Yes, sir.
They're standing 1 row back and hearing things from God knows where, but not you.
Okay, thank you.
Other question, comment? Kurt, you okay with it?
Yeah, yeah, you did good. In terms of the end comments about sort of urgent surgical care, it's pretty obvious we're going to the OR with this. You can't leave a baby with crap hanging out of his belly like this, so you got to go to the operating room. So I wouldn't really emphasize that.
Okay.
I'm still not sure Now, I should have known which one of the figure 4 there is what your child, the baby, had.
That would be A.
Okay.
Except
It was an
it was
open
prolapse.
fistula. It was an open fistula then.
Yes, sir. And that's a good point about the
Pointer.
laser pointer,
Yeah.
right? So you can refer to
Yeah,
that
but I mean,
as your.
Yeah, I think
where
that would
is it?
help, for sure.
Where can you see it on any, or can you see it on any of these pictures?
Yeah, let's see. So this
I
would
mean,
be-
I know you can see
yeah.
it there. I'm saying, can you
Right.
see on either 1, 2, or 3?
So you can see it on
you can
one, Dr. Burns, but the schematic doesn't show the prolapse.
Well, I mean, I think if you just
Yeah.
pointed it out, I mean,
Yeah.
you can't see it well, but this is where it is.
Exactly. I agree with you. Yep,
Yes, sir.
it's a good point.
Okay.
These will be on a screen, is that correct? They're not.
Yeah, so it is a screen, yes.
Remember, it's a smaller, we're not dealing with as big a screen too, so understand your scale's gonna be a little smaller.
Right. Got it.
It's okay to say you can't really see it here, but this is where it was. I mean, as far as.
Right. Sounds good.
All right, Dr. Harold.
All right, thank you.
What'd you say?
Make sure the laser pointer works on like a LCD screen.
Oh, good point.
He hasn't made it yet. That's okay. Thanks. Good morning. My name is Kevin Harrell. I'm a second-year resident at the University of Tennessee, Chattanooga. Today I'm going to be sharing with you a recent case of an atypical solid variant serous cystadenoma of the pancreas. Serous cystadenomas are a group of pancreatic neoplasms that are typically benign and infrequent. They account for about 16% of all cystic neoplasms of the pancreas. The typical features include non-aggressive features, single lesions that are often larger, they have a central scar, and they most commonly present in women during the 6th decade of life. These are typically classified into histologic subvariants. The most common patterns are microcystic, macrocystic, and honeycomb. The solid variant is the rarest type with less than 20 cases reported to date in the literature. Our patient is a 72-year-old male who presented with a several-month history of vague abdominal pain, weight loss, and fatigue. He underwent thorough imaging workup, including MRI and a CT scan. A representative image is shown in Figure 1 with an enhancing, solid-appearing pancreatic mass shown in the uncinate process. The patient also underwent endoscopic ultrasound with biopsy, which was non-diagnostic, and his tumor markers were within normal limits. He was offered resection after a multidisciplinary review and was taken to the operating room for a pancreaticoduodenectomy. On pathologic examination, as you can see in Figure 2, despite the solid appearance on gross pathology, there were innumerable microscopic cysts present as seen under the microscope. These were lined with a bland cuboidal epithelium, and no aggressive features were noted. In fact, adjacent duodenal mucosa was not invaded at all. This was consistent with the diagnosis of a serous cystadenoma despite the appearance of a solid tumor. The patient recovered from surgery without incident, and the pancreatic duct stent that was placed intraoperatively was taken out 4 weeks afterward. So this presents a diagnostic challenge to the surgeon in the diagnosis of these lesions. Though new immunohistochemical markers have been proposed, the resection remains typically the most prudent option for these solid-appearing tumors. Fortunately for our patient, a benign diagnosis was returned in the face of a possible malignancy. Thank you, and I'll be happy to take any questions.
Questions, comments, observations? Yes, Dr. Childs.
So a couple things. I thought that was very well presented, and secondly, I like personally my eyes like this format where I can go bullet points. That's just it doesn't like daunt you when you walk up to it and you see enormous paragraphs. So I really like that. I would say the only question I have is how does knowing this diagnosis, what does it change from a management perspective? So from this standpoint, what's the take-home point for somebody who's out doing surgery in the community who says, okay, what can I take home from this? What should they take home from this?
That this exists. I mean, I don't know that, the answer is that you're going to take, I mean, to be honest, you're going to take this out. It looks like it looks like a tumor. I mean, it looks like a adenocarcinoma or a peanut, and so you're going to take it out.
Well, I guess the reason I ask is you said there's new markers being proposed to aid in the, so if you can diagnose this earlier, would it change your management?
Possibly. I mean, you could do a less aggressive resection. If you have a smaller tumor, you could, proceed with an enucleation or something like that, and not a big cancer surgery, because they are benign.
Because I suspect that's what somebody's going to ask that question.
Okay,
So,
I can emphasize that.
Yeah, but where that's located, Dr. Mejia's done a lot of Whipples. I mean, where that's located, it'd be hard to do without doing a Whipple, wouldn't it? Yeah, on the sides. I mean, even knowing it's benign, I don't think you'd be able to do that, which is, and this is something, as long as the patient survives the operation, then this is a life-saving procedure, so it sort of confirms the fact that a good general surgeon needs to know how to do a Whipple, right? And we need to still know how to do it, because obviously pancreatic cancer doesn't have very good prognosis, but this does. Other questions, comments? Yes, Dr. Barker?
If you would just say you're a surgery resident, I think everybody says I'm a resident at, you would say you're a surgery resident.
Sure, absolutely.
Yeah. I did mean to go back. I don't remember now who used it. Maybe it was you, Jacob. There's no such thing as a patient that's an unfit surgical candidate. There may be a poor one, and there may be somebody who don't want to operate on them, but they're not unfit. If they're breathing, they may still be fit for an operation. Okay. Any other comments? Well, these are well done, guys. Good job. Get with your mentors about the issues that you need to do, and look forward to good presentations down there. Thank you.
Assisted